that we can share. If you do not want to be recorded, this would be the time that you would have to leave the webinar. So, hi everyone. Thank you so much for joining us in this webinar called Let's Talk About Speech Therapy for Your Child with DDX3X Syndrome. Hi, my name is Paula Pando de Gil. I am a part of the Leadership Advisory Board at the DDX3X Foundation, and I myself am a mother of an almost 10-year-old amazing DDX3X girl. I'm going to share a couple of housekeeping points before we get started. The mics will be off for the entire presentation, and all questions will be answered at the end. We encourage everybody to drop any questions that you have throughout the presentation in the chat if you didn't get the chance to send them ahead of time. And we will try our best to answer all the questions at the end, and hopefully we'll have enough time to get through all of them. We are very excited to share this webinar, which is intended to provide general guidance for parents from this amazing expert, Beanna Wadrup, who also happens to be my own daughter's SLP since January 2021. So I've known her for 5 years. I'm going to read a little bit about Beanna's bio so everybody knows who they're talking to because they don't personally know her like I do. So Beanna Wadrup, MS-CCSLP, is a speech language pathologist with over 17 years of experience, 14 of which have been focused on the diagnosis and treatment of motor speech disorders, particularly childhood apraxia of speech. During this time, she has evaluated and treated hundreds of children with motor speech disorders, utilizing a variety of evidence-based motor treatment methodologies. Beanna is passionate about individualizing therapy to the child's current needs, so she has not only undergone extensive training in motor treatment methodologies, but also methods for facilitating emotional and sensory regulation, as well as supporting language development for both analytic and Gestalt language learners, which my daughter also happens to be. She has also addressed literacy challenges for many of the children she treats. Beanna continues to maintain a small caseload of children with motor speech challenges and is continuously learning how to best support all children, including children who are neurodiverse and from diverse backgrounds. So I am going to pass it over to Beanna so we can get started.
Okay, thanks so much, Paula, and thank you everyone who was able to join us here live. So let's go ahead and jump in with talking through speech therapy for your child with DDX3X syndrome. And I'm going to go a little bit quickly through this part so that we have plenty of time to answer questions. So there are my disclosures. Mostly, as Paula mentioned, I am being compensated for this presentation. And as she mentioned, the other main one is that I do treat her child. So overall, my goal for our time here together is to really empower and equip you to know what to look for and ask for in speech therapy for your child with DDX3X. We're going to quickly talk through some definitions, then talk a bit about apraxia therapy and what that looks like, how we can individualize support, how we can and do that by combining therapy approaches, and then talk through what therapy sessions might look like and also discuss ways that might help you to find a therapist. So going through our definitions, one thing that I definitely wanted to touch on is that neurodiversity is the idea that there is natural variation in the way brains work. We all learn different ways. We all behave certain different ways. And there's not necessarily one right way for brains to work. So a lot of times we'll hear individuals with autism referred to as being neurodivergent, but this also includes individuals who have ADHD, sensory processing differences, learning differences, including dyslexia, mental health conditions, and more. When we talk about communication, that's kind of our big umbrella term, and that's really that process of exchanging information and ideas. So, of course, that's both us expressing our ideas and information as well as understanding it. The expression can take many different forms, and it doesn't necessarily have to be symbolic. So we can express things in ways like gestures and things like that where the meaning isn't necessarily symbolic. Part of communication is language. And when we're talking about language, that's really more of those cognitive processes. And when we're talking about language, we're talking about using a symbol system, so a symbolic system for communication. So this, of course, can include spoken words where we've, within a language, it's agreed that this word symbolizes this thing. Similarly with written or other communication systems, again, where we have that symbolic representation. And of course, language, we can include what we're understanding or that receptive language and our expressive or how we're communicating with others. And then we also have speech, which is also part of communication, but is really specifically just how we say sounds and words. So again, overall communication is that like broader topic, and then part of communication is language, that symbolic part, and then part of it is speech, just specifically how we say words. And of course, there is some overlap because we do use speech as part of our expressive language. A quick note on verbiage, you'll hear the terms nonverbal and non-speaking, and many people use them interchangeably. I use the term non-speaking because nonverbal means without words. And many non-speaking individuals have told us that they do have words. They understand a lot of words. They have words that they communicate in other ways, like sign language or with a communication device, but they're not maybe able to speak those words. So you'll hear me primarily say non-speaking because I've worked with many individuals who do have many, many words, but really struggle to speak those words. But you will hear them used interchangeably. So when we think about speech production, this is an overview of kind of what that process is. This is a little simplified, but it gives us the idea, right? So it starts with a thought. We all have, of course, many, many thoughts throughout the day. And then there are some of those thoughts that we want to share with someone else. So we have communicative intent. Okay. So we want to share those thoughts. And that can vary. Some people have more thoughts that they care to share with others. Some people have more than others. But once we have this thought that we want to share with someone else, then we go to a part of our brain where we store our vocabulary and pull all of the vocabulary words that are needed to express that thought. Then once we have the words selected, another part of our brain picks the sounds that are needed for those words. And then we go to the motor planning where it's going to sequence the sounds in the correct order to produce those words. And then we have what we call motor programming, which is telling which parts of our body, of our mouth, our vocal folds, even with our breath support, what has to move when, which muscles are going to move when to make that sequence of sounds. And we call that motor programming. And then we have actual movement where we actually have motor execution. So this is where the muscles actually move, including like our diaphragms moving we talk when we're exhaling, as well as controlling our vocal folds, our lips, our tongue, all of that. So there can be disruptions in any part of this kind of pathway that can interfere with the end product being here, actual speech. So it's really important to think about this, and this is why we say diagnosis determines treatment. Because if you are having a concern in one of these areas, we really want to make our treatment as specific to the actual cause of your issue as we can, because there can be breakdowns in any part of this pathway. And the more we know about what is actually causing the difficulties with speech, then the better we can make treatment to discuss that deficit. Because we don't want to be designing our treatment to maybe target an area that's not actually what's really interrupting with that production of speech. So we're talking about today motor speech disorders. There are two big ones that we talk about for children, and those are childhood apraxia of speech and dysarthria. So these are neurologically based speech sound disorders that affect those last three steps, the motor planning, programming, or execution of speech movements. So that affects how the muscles for breathing as well as those other parts move, and that can cause speech to be hard to understand. So again, we're talking about those last three parts of that sequence. So, what is dysarthria? Dysarthria is one of those motor speech disorders in which children have difficulty moving with enough strength, precision, and range for clear speech. So, they may also have issues with breath support or voice quality. Children with dysarthria know what they want to say, and they have adequate mouth structures, meaning they don't have something like a cleft palate that's interfering with their clear speech production. So, and there is a study from 2024 where they looked at children with DDX3X, and they did see that some of the children that they were able to test did have dysarthria. So it's often associated with other neurological markers like things like low tone. And again, it is often children have some weakness. So it's really that motor execution. We're actually looking at the innervation for the muscles, and that's why, again, there can be low tone and weakness associated with that, and that's that stage that's affected in dysarthria. With apraxia, children with apraxia know what they want to say. They have adequate muscle strength, so there's not an issue with weakness there. And they have those adequate mouth structures, so they don't have a real physical difference like a cleft palate. But they have difficulties in those last two steps of planning their speech movements and moving with the right amount of tenseness for the right amount of time and how overall to move. So in young children with apraxia, or children who might be older but have co-occurring challenges, this may mean that they're really quiet children. They might not vocalize much, or what they do may be a lot of grunting or squealing, not really specific movements with their mouth. They may rely on certain safe communication partners that they know can understand them, and might be more shy or hesitant to engage with people who aren't as familiar. They might prefer to play on their own instead of with same age peers, although clinically I've often seen where they interact or play well with older children or adults who can kind of understand that they're having a difficult time talking and can kind of compensate for that. So you'll often see these children watching more and listening, but not necessarily joining in. In older children who are talking, their speech might be difficult to understand. It might sound kind of robotic or monotone or choppy. Sometimes people say it sounds like someone has an accent because there's some vowel differences and other differences in their speech. They may overall use less speech, like have a tendency to go towards single words or short phrases instead of entire sentences, or they might mostly use content words and kind of omit connecting words, and they might have grammatical errors. So CAS is diagnosed by a speech-language pathologist. It is that speech sound disorder, so there might be an underlying medical cause that's diagnosed by a physician, like a genetic syndrome like DDX3X. But this is actually a speech sound disorder, not a medical diagnosis. So a speech-language pathologist has to listen and watch the child say a variety of words of different complexities and lengths, and note the errors, and they're looking for these characteristics in the child's speech that indicate there's that trouble with motor planning and programming. And then it's also important to do the assessment dynamically, where the speech language pathologist actually provides multisensory cues. So this can be things like touch cues, gestures, other visual cues, producing things simultaneously to see how the child's system responds to that cueing. But here we get to a catch-22. And the catch-22 is that to formally diagnose apraxia, we know that we have to see these characteristics across different speech tasks. So we get into an issue where a child isn't talking much, or isn't yet talking very much. And if that's the case, and it is due to difficulties motor planning and programming, then we kind of get into this cycle sometimes, because the child can't do enough tasks to diagnose apraxia. So then they don't receive apraxia therapy. And then they don't make much progress with speech. So then they still are not talking very much. So if the issue, or a big part of the reason why they aren't talking, is this motor planning and programming, as I mentioned earlier, the diagnosis does determine treatment. So we know it's really important to use the right kind of therapy for that issue. So we do get into this catch-22 sometimes, which is why it's really important, if there is suspicion of apraxia, even if we can't formally diagnose it, we should treat it as if it is apraxia. So if we're seeing some of those characteristics, some of those indicators, perhaps we've ruled out other things, then it's important to do at least a trial period of apraxia type therapy to see if we see a different rate of progress, to see if the child's responding. And then as they're responding and talking more, we can do more of the assessment and perhaps get to that formal diagnosis over time. I also wanted to touch on augmentative and alternative communication, which includes all of our communication abilities, including things like communication devices, but also signs, gestures, writing, and pictures. So there's been a lot of research on AAC with a lot of different populations at this point. And in this last summary of research, and this was on individuals who were not neurodivergent, in this study, the individuals who worked on speech and AAC most improved with speech, and no one showed a decrease in speech. So we know that for AAC, there can be huge benefits, and there are really no negatives, especially on speech development. So in that 2024 paper that looked at children specifically with DDX3X, this was one of the big recommendations, is we know that many children have a motor speech disorder, which does mean it's going to take longer and more therapy to develop speech. And so the authors of the paper really stressed that we should also be starting AAC as early as possible. And we know it will only help speech and not hinder speech. So when you're talking about AAC, you'll also hear something called aided language simulation, which is where we're modeling multiple forms of communication. So we'll be using speech, we'll be using a device, maybe we're also using signs or gestures, and we're making it and we're accepting whatever the child's able to do to communicate with us. And overall, we're thinking about treating the whole child. So that's where we're really going to start individualizing, because yes, there might be motor speech challenges, but there might also be other motor issues, developmental coordination disorder, autism, or other neurodivergent conditions, intellectual disabilities. So that's where we're going to really think about our treatments. And we want to make sure the child feels safe, regulated, and engaged. So regulation and engagement are key, meaning emotional regulation and sensory regulation. So the child's in a ready learning state, not overstimulated or understimulated, so they can learn what we're trying to teach them, in this case, communication and speech. So talking a little bit about CAS-specific motor treatment, you'll hear me reference evidence-based practice, which means we have our external evidence, and that's research evidence that's been done. Those are the research studies. Then you also have the clinician's experience and training. You have you as the caregiver, your perspective and experiences. And then we also have what's called internal practice, which is where we're talking about like the setting, because this can be different for like a school versus home versus a private clinic. We do know from the research that external evidence that if there is a motor speech disorder, then we want to base our therapy on these principles called the principles of motor learning, which help us know how to best structure our therapy so that children are really focused on movement and are learning how to move better. And we also use that multisensory cueing that I mentioned earlier, which can be those visual cues and touch cues and a lot of different cues. So we're not just saying, I say it, you say it. We're saying we're going to say it together. I'm going to slow it down. I'm going to add touch cues to help you know how to move. For CAS and dysarthria to some extent, these are our evidence-based motor treatment methodologies, meaning these have enough research evidence that they're recommended. Now, these are for children who have apraxia. So in these studies, they haven't studied children who have many co-occurring conditions. So these are really specific to apraxia. And you'll find that there are other methods, but they don't have this high level of research evidence yet. So you may hear of other methods, and they may be effective for apraxia, but they don't have the research or external evidence yet. So overall, when we think about these methods, dynamic temporal and tactile cueing, or DTTC, the Nuffield, rest, and speech motor training, they're all designed to treat apraxia or motor speech disorders. But you'll usually see DTTC and Nuffield are more for younger children who are just starting on their speech journey, whereas rest and speech motor training are usually for older children who are more at the conversational level. So it's a little bit more about fine tuning, whereas DTTC and Nuffield are really kind of about getting started with speech. And then I put this in a handout for you guys that I'll show you at the end. That's kind of resources for you to learn about those different methods. But overall, when we're thinking about motor-based therapy, we want to think about focusing more on movement, using more cueing, giving more feedback, getting more trials or repetitions. And we have to be more responsive because we want to provide the right amount of cueing to the child at any given time. Now, I want to talk about individualizing support because all of those methods are very there's a lot of repetition and they're very drill based and kind of compliance based, which isn't always going to work for all of our children who are neurodivergent or may have sensory needs or other needs. So overall here, we want to presume competence, meaning that we are presuming that every child has thoughts and feelings that they want to express, and we need to provide the right supports for them to do that. So we're not going to limit their potential. We're going to presume that they have that ability given the right resources. And then we're also going to think about kind of balancing because we all know, like if you're having a big emotional conversation, you're not going to be thinking the most clearly or your most fluent and eloquent. Similarly, if you're in a lot of physical discomfort or pain, you're also not going to be doing your best thinking and talking at those moments. So we want to definitely think about this because it's even more so true for our children who have challenges in those areas, meaning that if we're really trying to work on one area, we're going to try to really support the other areas as much as possible. So if we're working on a language task, they're not thinking about, something that's physically uncomfortable, or they're not or emotionally not regulated. So overall, looking at combining these therapy approaches, we're talking about AAC, we're working on those communication building blocks, and we're working on movement and motor speech, with regulation and connection being the tie that binds all of it. So I think about it as making a cake. So our cake is really our foundational core part. We're working on that regulation and engagement. A child has to be able to focus and engage with us. So that might mean sensory regulation, emotional regulation, using movement to help stay there and stay engaged. Then after we have our cake, we put our icing on, and that's our communication and language. So we do that by following the child's leads and interests and finding out what they want to communicate about. And then we add on our candles and our sprinkles and things like that. And that's where we really start working on that speech. So we have this really strong foundation. We're regulated, we're engaged, we're communicating, and then we start trying to work on getting specifically speech. So we don't want to put the cart before the horse and try to work on speech before we have some of that really great foundation. We're usually working on those things simultaneously, but we've started with the cake and the icing before we're laying that speech on top. So my therapy sessions are highly individualized to the child, and we have to be ready to pivot all the time. So for example, one session might be that we're doing sensory play, getting the child regulated, and then we're following their lead, finding out what they want to communicate about, and building our targets into that. So we're using AAC throughout, doing total communication, and then we're putting in speech when we can. So with a lot of those apraxia methods, we'll do like the same target many, many, many times in a row. What we find for children who are neurodivergent is that we want to keep it in context. We want it to be meaningful. So that might mean we get smaller little chunks of speech practice throughout the session. Another example is we might do something more structured where we have some sensory play, we get regulated, and then we have it on a visual schedule that we're going to do mouth words. So I tell the kiddos that we have words with lots of different ways. So we have words we do with our hands, we have words we do with our mouth, we might have words we do with our device. So they know, hey, at this point, we're really going to think about using our mouth words. Now, they can use any communication they want. That's always accepted. I would never ignore them using their device or their sign, but they do know, hey, this is a time when we're really going to talk about moving our mouth. And so we might do that. Then we might do a sensory activity, do child-led play, and then do mouth words. And if there's other times to practice speech within that play or sensory activity, then we do. So another example, and it's always just individualized, like if I have a child who really, really loves books, then we'll do our mouth words with books if that's what really they like to do and talk about. And then another key point I wanted to talk about is just how therapy changes over time. So there are many, many different progressions that you may see. So you might have a child where you're really starting with AAC, and then you're starting to do some more apraxia therapy like DTDC that I mentioned you usually do with children early on in their speech journey. Or you might do Nuffield instead. Or your child might progress to where then they're up to the conversational level and we end up doing something like rest. So you might go through multiple different treatment programs, not because they're not working, but because they are working. So, you use DTTC, the child is talking more and more, then DTTC is no longer the right fit. Because remember, these programs were all designed for children at different stages of speech levels, and they were all developed to treat apraxia, but different in different ways. Some are more early words, some are more conversational. So there's many different progressions we can have, including building in language and things like that. So we might start doing where we're more focused on language, then we're more focused on speech. And there's lots of different possible options. So just keeping in mind, you're looking for what your child needs now and what is the right fit now. And that doesn't mean that that will always be the right fit. Talking through a few things that I wanted to tell you guys about interviewing a therapist, because when you're looking for the right therapist, you do want to ask some questions before you get started. Like, what experience do you have evaluating and treating motor speech disorders? Because speech language pathologists have a very big scope of practice, and motor speech disorders is only a really small part. So hopefully they're going to tell you that they have training and experience in multiple treatment methods, not just one method. Because as I said, what works now might not always work, or it might just not be the right fit for your kiddo. So you want them to have more in their toolbox, if possible, and to have treated more than one child. And you want to ask, what types of outcomes have you seen for your the clients with motor speech disorders? And an honest answer means a range of outcomes. So it shouldn't be, oh yeah, everybody talks. It should be, I have this range of outcomes. Some children become conversational. Some children get to short phrases. There should be some outcomes with spoken language, but also, like in my experience, I have had a few kiddos where we were not able to make progress with speech at that time. The vast majority of children I've treated, we have made progress with speech, but again, what that final outcome was differed. And then how do you approach motor speech disorders differently than other speech disorders? And this is, again, where that diagnosis determines treatment, because if there's an issue with how sounds are produced or there's an issue with vocabulary, those are different things than that motor planning, programming, and execution. So again, if it's more of a motor-based disorder, then we want to be talking about multisensory cueing, and we want to be talking about the principles of motor learning. And then also, what is your experience with working with AAC? Because again, we know from research, we know from clinical experience that AAC will be a part of many, many, many children's journey. And so we want someone who knows multiple forms so you can pick the right one for your child. And we want them to also be talking about total communication or aided language stimulation, where they're pairing speech and AAC. And then also asking how they include caregivers in the process. I like to give caregivers the option to observe therapy or even participate, definitely help with target and goal selection, and give home carryover activities or some combination of that depending on the child and what works. But you definitely want to hear about how you're going to be involved. And then also asking just how therapy sessions look. So again, hopefully they're talking about individualizing it to your child, making sure the child's regulated and engaged, and incorporating movement. And these are, again, this is in the handout, but these are all links specifically to these nonprofits where they list clinicians, SLPs, who have varying degrees of experience and specialization in apraxia. So that's it. As far as my part of what I had prepared for you guys, there is this free resource download that has all those QR codes, because I know I went through those quickly. It also has those interview questions that you could ask a therapist. So hopefully that is helpful, and I'll leave that up as we go through and answer some questions. And before we dive in, just a quick note. So the answers I provide today are meant to be general guidance and not professional advice. Every child's journey is unique, and since I haven't formally assessed your child, what I share may not apply to every situation. So if you have specific concerns, I encourage you to reach out to an SLP with a apraxia experience in your area for a differential diagnosis, or reach out directly for personalized support through the resources I provided so we can connect.
Thank you so, so much, Brianna. I know that that was a lot for everyone, and I greatly appreciate it because, having been in both sides of the journey, just for general knowledge, my child was non-speaking until she was 5, and now she is almost 10 and fully intelligible in English and working on her Spanish, which is my first language. Um, so we have been on all the sides of this journey, and I think Brianna, you did an incredible job just laying it for parents to understand and not SLP directed, which is kind of sometimes we get that type of guidance. But I will not take more time, and I'm gonna jump in first with some of the questions that were sent in ahead of time. I think you answered some of them, but for like the recording, to make sure, there was someone that had asked, what does apraxia look like as a child ages? And how
Mhm.
should therapy for apraxia change as a child ages? You touched on it, but if you could expand a little bit more for
Sure. Yeah. So often when a child's young, then apraxia can look like silence. They tend to be very quiet. I've even had children who, even as babies, like they would laugh silently, things like that. So coordinating all of the movements. So a lot of times there are children who are quiet. They don't babble a lot. They're just not producing a lot of speech sounds. And then as they're developing speech, it can also mean that you hear a lot of inconsistencies, meaning that sometimes they'll say a word and then other times they won't say the word, or they'll say a word many different ways. Or like there will seem to be some situations when they can say a word or words and other situations when they really can't. And then and then as they build more speech, then what you'll hear is often those difficulties with understanding them where the speech isn't clear, or that monotone or kind of robotic or choppy sounding speech. And again, maybe shorter phrases or grammatical errors or again, a lot of people who aren't speech language pathologists feel like the child has an accent, even though the child is not growing up in an environment where they have, where they would have an accent. And that's just, I think, people's description of, hey, wait, this doesn't quite sound like other people's speech.
awesome. I will share a little bit of how it sounded for my DDX3X girl. There was a lot of or a lot of screaming, a lot of
Mhm.
screaming for a few years. We didn't get the apraxia diagnosed until she was almost 4, or suspected apraxia, and
Mhm.
we didn't get a differential diagnosis until January 2021. And then we didn't really have those, sounds. And as she progressed, she was able to say a few more intelligible sounds, but it wasn't maybe until 2 years ago or so that it was intelligible to everybody because I could understand her, but she had sign language for like 400 signs at the beginning for the first 5 years of her life, and so it sounds very different as they grow or as their speech journey progresses.
And that's where we want to have therapy look different too. So at those early stages when they're not producing much, we really want to give them other methods to communicate because we don't want to wait. I don't know how long it's going to take to get the mouth moving the way it needs to, and we can't wait for that to happen. So that's why we're giving sign language, we're giving communication devices, we're giving other ways to communicate. There's tons of benefits to that. And that doesn't mean we're not going to work on speech, but we need to make sure that's in place so that we can decrease frustration, decrease anxiety, increase regulation and engagement. And then we can start targeting that speech. So that starts with a few words. And in those early stages of apraxia therapy, it can feel like you're going to have to teach every single word the child ever says. And it's not true, but it definitely feels like that in those early stages. But as we get the motor system working, it becomes a positive self-feeding cycle. We're doing the principles of motor learning to make the motor speech system more efficient. As it becomes more efficient, it can learn on its own. So at the beginning, yes, it's like building a house with Legos. But it doesn't stay that way for most children forever. They usually are start to learn more on their own. And then we can get into where there's specific errors or sometimes those differences in their inflection where it can sound kind of choppy, or we get into more of that interplay with language where there might be grammar issues and things like that. And then we're going to change our therapy to specifically address those issues because those are different than what it was at the beginning when we're working so hard to teach them how to move for every single word.
Yeah, and it's a lifelong condition, right? And so
That's correct.
yeah, when you think that they've learned all of it or they have the motor plans, it'll sound different. Like my child can say Guatemala, but she can't say Guadalupe, which are very similar words. So we had to work on that. I'm going to jump on another question. Our daughter is 6, soon to be 7. She's nonverbal, and we've been working with outpatient therapy using an AAC device. She doesn't use it properly yet, but we work on modeling and try our best to get her to use it. Our school speech therapist has her using their own iPad with a different software. And then there is also an AAC specialist with the school somewhat involved, but feels as though switch toys are more level of capability. What's your recommendation when there are multiple opinions involved, and would using all three forms of communication likely confuse her more?
So again, generally, when we're talking about different communication devices, they basically have different languages. So I can tell you as an adult with excellent language skills, I use multiple different communication apps with multiple different children. But when I go to a session with one child where I'm using LAMP and then immediately go to another session with a child using Proloquo and then go to another session, I mean, it's like when you hear a foreign language and it takes you a minute to like be like reset. Because I'm of course using all of those. So they're all languages. So generally, we really recommend selecting one program and going with that because asking to switch, especially as a new learner, can be really tricky and it's not necessary. So we encourage like trialing and seeing which system the child responds to better because they are different languages that are structured different ways. But then go ahead and pick one and stick with that. So, as far as the difference between like a device and switches, the big difference that comes to mind there is what we call a robust vocabulary. So with these communication devices that have these huge vocabularies, with those, we're really presuming competence. I'm not assuming I know what the child wants to say. I'm putting a lot out there so that the child can select what is really meaningful to them because if I guess, I'm guessing. So that can be a limiting factor with using some other methods where we might just be doing like buttons or something like that because we're selecting the vocabulary for those buttons and it's going to be by definition just really limited. And I have had experiences where I have picked the wrong word and the child didn't care to say that word with a device or with speech. So when we provide that really robust vocabulary, we're not limiting the child, and we're letting them show us what they are thinking and what they want to talk about. And then we're going to get more motivation and engagement. So, um,
Awesome.
that's a tough, personally to navigate amongst your professional team. But I think it would be something like, hey, we all need to get on the same page for my child. So whatever kind of meeting or however you think that needs to happen, but an executive decision needs to be made and we need to have buy-in from the whole team, to work together.
Love it. I think that was very, very helpful. Okay, my daughter has an extremely high and narrow palate in her mouth. You can see how it affects her tongue when trying to make words. Are there any recommendations for helping with this besides going to a dentist?
Um, so generally a high and narrow palate is related to myofunctional disorders. So I would say you would want to see a professional who can evaluate your child's function. And that does include function for speech, but it also really includes airway. You want to make sure that the child's airway is really open, including during sleep and all of those things, because of course, breathing affects everything. It's very foundational and critical. And so what so that's where my like first concern is airway okay? And so a lot of times now you're looking at a dentist who's an airway centric dentist, sometimes an ENT, and or a myofunctional trained professional, which might be a speech therapist, could be other professionals, and you're really looking at function, not just for speech, but for eating and breathing as well. So that's the direction I would head with those types of concerns.
Perfect. Thank you. So, how old does a child have to be diagnosed with CAS?
So there's not a certain age. There's not a certain age. We do want to consider age for children under the age of 3 because so much motor development is still happening. So there is a specific motor development that happens with our mouth. We know that what a 1-year-old can do with their mouth, the amount of control they have is different from a 2-year-old, a 3-year-old, and a 5-year-old. Just like their motor skills are different with everything, like how a 1-year-old walks is different from how a 2-year-old walks and how a 3-year-old runs. So when the child is under the age of 3, we have to really think carefully about motor speech development. That doesn't mean we can't diagnose apraxia, but we have to think about it through the lens of this child has some motor skills that aren't expected yet at that age. The main thing, rather than an age, is the ability to engage in that multisensory cueing and produce words of different levels of difficulty. So we really have to have enough speech. As a clinician, I have to have enough speech that I can look and say, oh, I see this kind of pattern of these characteristics that tells me that motor speech system is really inefficient. So that's more of the criterion rather than an age, because I've had children who weren't producing enough speech until they were 5 years old, 10 years old. So, for that child, a conclusive diagnosis wasn't an option when they were younger. Again, that doesn't mean if we're seeing indicators, even if we can't come to that official formal diagnosis, we can use a working diagnosis like suspected childhood apraxia of speech, and we can begin, or suspected dysarthria, we can begin treating it as if it is, because then again, we're trying to get into that positive self-feeding cycle where then the child can produce more speech, so we can look for more of the characteristics and get to that formal diagnosis over time.
Yeah, and that was exactly what happened with my child. She didn't have any sounds. Well, she had 8 sounds, no words. And the first time an expert in apraxia tried to diagnose her, she told us she didn't have enough to be able to diagnose her. But in her experience, which was, I don't know, over 20 years of experience or anything, she's like, I'm pretty sure it is, and you should look for somebody that can provide that apraxia support. And that's how I stumbled upon with Beanna, and it was a game changer for us. So I think that with your answer, thank you. It also covers the next one that was, would you recommend starting speech therapy in a child under 18 months?
So that I would definitely recommend therapy for language and an AAC. And so if your child, you have risk factors, then yes, I would. I wouldn't necessarily be focused on motor speech yet at that age, but I would definitely be looking at supporting language as much as possible, supporting communication, and starting AAC. And children can start AAC, including communication devices, really young. I'm sure most of you have been amazed by some kids' skills on iPads. But we know that there are not prerequisites for AAC. So we can start, just like you've probably heard of baby sign. We can start baby sign. And yes, we can start communication devices under 18 months. So that's the way I would be looking, knowing that your child has these risk factors for having speech and language issues, given their medical diagnosis.
Great. So, what are your top three tips for treating children with apraxia?
So this is a very tough question, but a few things I would say is number one, start where the child can succeed. And so what I've seen happen a lot of times is that people try to start at too hard of a level and the child's not able to succeed. So they're just failing, failing, failing. And that's not a positive situation for any of us. So meeting the child where they are and starting where they can succeed. For some children, that means we're not starting with speech. We're starting with movement. We're starting with engagement. But a lot of times I do start with just movement with kids. Like I'm the person that helps you move. And at the beginning, that might be we're moving our arms, we're moving our legs, we're moving our bodies. But start where they can succeed, or maybe sometimes that's even like sound effects with some kiddos, or it's just we're doing things like I'll be like, we have to move this wall, and just like getting vocalization. If that's where they can succeed, that's where we start. And then also just from the beginning, also focusing on that communication overall. So being a good communicator, and then also, but also talking about movement. So I start talking about movement right away. Like, let's move together. Let's move this way, move that way. Because when we do get to motor speech, it's about how we move our mouths, not necessarily how it sounds, but how we move. And then the other thing, if you are working with a child with apraxia, is to use simultaneous speaking. So I talked about multisensory cues. They are very helpful, but a huge one that I feel like can benefit so many children and that parents can easily incorporate is simultaneous speaking. And that's when we say the word or the sound or the phrase at the same time as the child so that they can hear and see what they need to be moving as they're doing it. So that's a huge one. And unless you do a lot of motor speech therapy, you don't necessarily know about simultaneous speaking. And I'm talking about speech therapists. Speech therapists do imitation, which children typically learn in imitation, right? We say it, they say it. But children with motor speech disorders need more assistance than that. So if we're going to work on saying me, then I say me, and then I say, okay, let's say it together. And I will prolong those sounds so the child could try to join me in saying me, and we're doing it together. It's kind of like I think about when you learn other motor skills, like you're learning to swing a golf club. You can watch the professionals do it on TV over and over. If you can actually have a professional come put their arms around you and take you through the movement, you're not going to have it right away. You're still going to have to practice a lot, but your rate of learning is faster. So simultaneous speaking is how I feel like we can try to do that with speech. So even doing things like it's almost like singing or something like that, but just very small pieces and doing it together would be another top tip.
Awesome. I think with that, you answered another question that was, what are your top recommendations for what as we as parents can do at home to help our kiddos with speech development? My girl talks all the time, but it is very hard to understand her. So I think you
Yeah.
provided some of those.
So if you can have, yeah, if there are some words, we also want to look at, I said starting where the child can succeed in speech terms, we call that stimulability. So knowing like what are some good targets for your child and then being, and are they at the level where you saying it with it can really saying the word with them or the phrase really helps. I would recommend that. For kiddos that are maybe not to that level yet, you can still focus on movement and do a lot of talking about like moving together and also talk about moving their mouth and increasing oral awareness. So that's things like, hey, can you open your mouth? And the way I'll start with that is I know your child can open their mouth, but they might not be able to do it on what we call on command. So when asked, but when you're bringing a spoon of ice cream toward their mouth, they can open their mouth, right? So I'll start with open your mouth. And then I do it simultaneously, which by the way, most of us do. Open your mouth. When you're feeding a baby, watch, you'll open your mouth. but no matter if what your child's age is, and then you associate that, and then you're like, yes, you opened your mouth, and then we can kind of fade that cue where the spoon doesn't have to be right in front of their mouth. It can be further away. It can be further away until we can just say, open your mouth. They can open their mouth. Guess what? We're going to start working on speech. When we say the word on, I'm going to start with saying, open your mouth. On. Okay, so working on some of this control, also just doing silly faces, and being aware of like labeling lips. Again, I'll use ice cream, chapstick, whatever, like putting it on the lips. Those are your lips. Yeah, feel your lips, feel your lips. Let's do silly faces with our tongue, or put something on there and they're getting it off with their tongue. Oh, you're using your tongue. Good job. Because when we start cueing speech, if I say, okay, let's start with our lips closed, if the child doesn't really know where their lips are or that they have lips, then that telling them that is not helpful at all. So having that awareness, but again, let's make it fun. Let's make it games. Let's use things they can already do. Start where they can succeed, with building that awareness. So it's a lot of labeling and then just doing some fun things. Let's try to lick our nose, silly things like that. Maybe doing a mirror or maybe recording yourself on a device because kids love to see themselves and then they get to watch it again. So those are also all things that you can do at home to help your child moving in the direction and building some of these skills that then will continue to be built upon in therapy.
Awesome. Do you recommend ever making an AAC program switch? Which, in your opinion, fits our girl best? My daughter's been using Touch Chat since pre-K, but she's not very engaged.
Mm. Yeah, so definitely that. So I'm always hesitant to make a switch if a child's doing well with a program. If you've really put in the time and effort and the child's not responding, then it might be time to trial something else. So, for example, I have the most experience with one program, right? But if a child comes to me using a different program and they're using it and doing well with it, then I would never recommend changing. I will learn the new program, and I have. I have learned multiple new programs for that reason because a child came to me and they were using it. But an AAC can be a slow build sometimes. Sometimes we think, I don't know if this is working, and
That's it.
then
I'm just getting out of this because
we'll hit a tipping point where we realize it is. But so that can be a hard thing. I would say talk with your speech therapist about it in depth and maybe even say, let's just try something new a little bit and see if we see a different response. Because maybe what you picked isn't the best fit, even though maybe it seemed to be at the time when you guys picked it.
Okay, I am going to ask how to improve oral awareness for these children.
So I kind of touched on that already some with like open your mouth, talking about the different parts of the mouth and how they move. So, you can point out things that the child is already doing. Like, oh, I saw you move your tongue, or I see you using your lips, or I see you opening your mouth. And then again, like trying to build some awareness, sometimes using some kind of sensory heightening things like ice cream or something that's very cold and putting that like on their lips or on their tongue to really increase awareness, as long as, of course, they're comfortable with that and they like that. I mean, you're not doing anything that the child doesn't like. So hopefully I say ice cream because hopefully your child likes that, or something else, a preferred item. And then, yeah, like playing different silly games, making different silly faces, and a lot of describing and talking about what you're doing is how I would work on oral awareness. And also make sure that you're talking about movement, like we're opening our mouth, or we're closing our lips, or we're moving our tongue out, or moving it up, or, like I would try to also include those kind of movement terms when talking about their oral structures as well.
Okay, there's a couple here that I can help answer as well. Like, what about adulthood? Is there an adult apraxia? So, childhood apraxia is speech that only means that it is from birth. but it's a long life diagnosis and it's not something you grow out of. So it would still be an adult with childhood apraxia of speech, basically.
Yeah.
But it's called apraxia only at that point. And then another question was we've been trying to get an apraxia diagnosis at our local children's hospital. However, was told that because our child is non-speaking, they cannot formally give a diagnosis, and we're giving take-home activities to work on. Do you have any advice? You already addressed that. It's the suspected apraxia. So that's just a lot of parent advocacy and going back to say, it's like, I can understand you cannot give me a diagnosis, but can we work on it as suspected apraxia, unless you have something additional that you have not already shared on that, so that we can get through as many
Yep.
questions as possible.
Sure.
Um, any thoughts on why some days my daughter talks and talks, and other days she only grunts and screams?
Well, certainly we all have, social emotional, and some days we talk more than others and things like that. So, of course, there is that.
Okay.
But from the motor speech perspective, a significant part of apraxia is inconsistency, meaning that when these neural pathways are new and not necessarily super well used or established, I think about it as kind of like you're going through the woods and there's like a trail and it's not been used very much. Some days you find it and some days you don't, and some days it's a little different. The more that trail gets used, the more that path becomes wide and apparent and easily available, right? So that's kind of how I think about the neural connections for kiddos, is that some days they can't find the path, or they can only find the path from a certain place. So if they're not in that situation or place, or they're not that regulated, things like that, then it's not accessible. So again, I think about things like social emotional, that where I showed that we have to have our needs balanced. Because I would also be like, hey, is there something sensory or physical happening that day? Where that path's not well enough used yet. Or if any one thing's off, it means that we don't have that availability. And that's also part of the reason we always want to have other methods of communicating available, because of that inconsistency. Some days the kiddos can find the words and some days they can't. And we know from a lot of our neurodivergent adults that are talkers, completely intelligible. I've heard from multiple adults that they'll say, when I'm tired, when I'm stressed, when I'm sick, the first thing to go is my speech. They're like, I lose my words. And so even though this is like, I've taken classes from autistic adults, they're teaching, they're very eloquent, but they will still say, I have my AAC device because when I get sick, my words go. So, keeping that in mind for our kiddos who are just learning and just establishing speech, how much more so it can be for them. So that's where my mind goes when you say some days we can talk and some days we can't.
Awesome. What are your thoughts on virtual sessions that SLPs are offering?
So it can be effective. Virtual sessions have been shown to be equally effective for things like language. For motor speech, it can be a little different because it is hard to do simultaneous speaking over telehealth. And obviously, you can't do touch cueing over telehealth. So, different ones, rest and speech motor training are excellent on telehealth. The earlier ones are trickier, like DTTC. But I've worked with parents really closely, and coached parents a lot, where the parent can help provide the cueing that I can't. So it's definitely possible, but it does take some more problem solving, in my experience. To kind of figure out, depending on what level your child, what stage they are.
Yeah, and just as a side note, we did virtual therapy the first year because it was middle pandemic when we started.
Mm-hmm.
So we just had to at that time, and it was a lot of work on our end as parents.
Yep.
And we did see a change in progress because she was so early on in her journey, DDTC and all that. That going in person was better, but now she really enjoys virtual. So, what kind of support is available when they use ASL?
Um, so, I mean, as far as, I guess, if you could drop in a little bit more specifically what you mean as far as ASL. If you're doing ASL, I think it's really important to have um, someone fluent in ASL helping to teach, especially when your child gets to that point. So they have that really strong model. Um, and so looking for resources in that way. And then I would say everything else as far as motor speech is the same, except that like when you're doing total communication, instead of doing like a device in speech, you might be doing ASL in speech. So those supports are the same.
Okay, I think we have time for one more. I know we're a little over, so thank you for your time, Brianna. Our soon-to-be 3-year-old daughter drools a lot due to hypotonia. We recently started her on medication for this, but doesn't seem to be helping much. We use Buzz Buddy at home too. Any suggestions for the drooling?
Um, so um, I would definitely look into, so I understand with low tone, that's certainly a factor. And I did want to touch on too that low tone does not necessarily mean that there's weakness. So those are two different things. A lot of times you do have low tone and weakness, but not necessarily. Because low tone is just the resting state of the muscles, you can't have low tone but be strong enough because when you actually recruit effort, you can still be strong. But with that resting position, I would definitely, again, double check airway and make sure that the child can breathe nasally. And because like if you don't use it, you lose it. So if we're not breathing through our nose, our nostrils will actually get smaller, and then it's actually harder to breathe through nose. And so then we get into that cycle. So a combination of looking at the tone and looking at resting mouth posture and working with either an OT or a speech therapist on that, but at the same time making sure that nasal breathing is a good option because that's what's the child is going to have to breathe nasally if they're keeping their mouth closed. And the reason I'm talking about that is because that is a big factor in preventing drooling is going to be to have a closed mouth resting posture instead of an open mouth resting posture.
One more and then closing. Do you feel that CAS is underdiagnosed because there isn't enough knowledge about it in the SLP field?
So paradoxically, apraxia is both over and underdiagnosed. So I get referrals from children who've been diagnosed with apraxia who don't actually have apraxia. And then now, at least in my area, I'm in Dallas, Texas. A lot of SLPs have enough knowledge to at least suspect. A lot of them don't have enough knowledge to feel comfortable formally diagnosing, and they're not super competent in treatment, but they suspect. They have enough knowledge to suspect. And there has been some research on this, and two, it is both over and underdiagnosed. Um, yeah, there isn't enough knowledge about it. That is true. And I think the lack of knowledge about an experience with apraxia is the reason that it is both over and underdiagnosed. There are other factors as well, but I think that's the biggest one. In graduate school, speech language pathologists are taught very little about apraxia, especially childhood apraxia of speech. Um, I can still tell you the three things I learned about apraxia in graduate school, and they weren't even correct. And so all of my training in apraxia has come from continuing education courses and on the job training with people who came before me who knew about apraxia, mentorships, things like that. And that's why, too, it's important to have those interview questions because a therapist is really going to have sought continuing education specifically on motor speech disorders to really have that knowledge.
And how would you mix that with those answers? Literacy. Like, what would be the approach with CAS and literacy together?
That could be a whole nother webinar,
And so we'll write
which
it down for that.
write it down. I'm happy to do a whole nother webinar about literacy. I will tell you that the reason I know anything about literacy is because I treated kids with apraxia, because I had to learn it. because so many of the children with apraxia that I was treating were struggling with literacy. Um, so,
That's
but I will say, simultaneous speaking.
okay. Well, I want to thank you so much for this incredible session, Brianna. I hope that everybody that was here live got a lot out of it, and everybody that's seeing it as a recording also benefits and can reach out. You have the resource to download. And I want to thank the foundation for the support and for giving us the space to be able to share with the parents. If you can at all and are able, please donate to the DDX3X Foundation so that we can continue research and the support for the DDX3X community. Thank you so much again, Brianna. And we will be in touch for that next one, maybe on literacy or maybe something else. If you have any recommendations or suggestions for us on how we can provide more information and resources for you, let us know. Thank you, everyone.
Thanks for coming.
Thank you. Bye.
Bye.